Hello everyone. Today's topic of discussion is treatment of asthma. The long-term management of asthma is well established with a stepwise approach. Let's start with the British Thoracic Society and Scottish Guidelines updated in 2016. The first step is to start short-acting beta-2 agonist inhaler, for example salbutamol, as required for infrequent wheezy episodes. As their name suggests, they are short-acting, so their effect only lasts for an hour or two. The adrenergic beta-2 agonists will relax the smooth muscles of the airways, resulting in the dilation of the bronchioles, hence improving the bronchoconstriction present in asthma. If the patient is still symptomatic, for example, if they're using salbutamol inhaler 3 times a week or more, or if they have had exacerbations of asthma in the past 2 years, then add low-dose corticosteroid inhaler, for example, beclomethasone. These work by reducing the inflammation and reactivity of the airways. If the symptoms are still not controlled on short-acting beta-2 agonists and low-dose corticosteroid inhaler, then the next step is to add long-acting beta-2 agonists, for example salmeterol. These work in the same way as short-acting beta-2 agonists, that is, dilating the bronchioles, but they have a much longer duration of action. After starting LABA, you have to assess the control of asthma. If the patient has good response to LABA, then you continue LABA. If there is benefit from LABA but the response is still inadequate, then continue LABA plus increase the low-dose corticosteroid inhaler to a moderate dose. But if there is no response to LABA, then you have to stop it, increase the inhaled steroid to a moderate dose, and move to the fourth step, which is either you add an oral leukotriene receptor antagonist, or oral beta-2 agonist, or oral theophylline, or inhaled long-acting muscarinic antagonist. Leukotrienes are produced by the immune system and cause inflammation, bronchoconstriction, and mucus secretion in the airways. So leukotriene receptor antagonists, for example montelukast, work by blocking the effects of leukotrienes. Theophylline works by relaxing bronchial smooth muscles and reducing inflammation. Unfortunately, it has a narrow therapeutic index and can be toxic in excess, so we have to monitor the theophylline levels in the blood. This is done 5 days after starting treatment and 3 days after each dose changes. Long-acting muscarinic antagonists, for example tiotropium, block the acetylcholine receptors. Acetylcholine receptors are stimulated by the parasympathetic nervous system and they cause contraction of the bronchial smooth muscles. So blocking these receptors will cause bronchodilation. The BTS say that there is little evidence to separate the different options available in the fourth step. They do, however, suggest that leukotriene receptor antagonists are least likely to cause side effects and they do not require monitoring of serum concentrations like theophylline. If the patient is still symptomatic, then the next step would be to increase the moderate dose of corticosteroid inhaler up to a higher dose in addition to treatments from step 4. Also refer the patient to a specialist at this point if they haven't seen one yet. Finally, the last step is to add oral steroids at the lowest dose possible for continuous or frequent use to achieve good control. The basic principles of using this stepwise approach to asthma are to start at the most appropriate step for the severity of symptoms, which means that in some patients prescribing a corticosteroid inhaler in addition to a salbutamol inhaler is appropriate at the first step. We should review the treatment at regular intervals based on severity, and we can step up and down the ladder based on symptoms. Try to achieve no symptoms or exacerbations on the lowest dose and number of treatments possible, and always check inhaler technique and adherence at review. The new NICE guidelines, updated in 2017, are slightly different from the previous BTS guidelines. The medications they recommend are the same, but they differ slightly in the stepwise ladder of which medication to introduce at what point. Most important thing to remember is that they both start with short-acting beta-2 agonist inhaler as required, followed by low-dose inhaled corticosteroid. But in the next step, we add an oral leukotriene receptor antagonist, that is montelukast, instead of a LABA. Now assess the control of asthma on leukotriene receptor antagonist. If the response is good, then you continue leukotriene receptor antagonist. But if the response is inadequate, or if there is no response, then we have to add long-acting beta-2 agonist. If the patient is still symptomatic, then switch the ICS and LABA to MART, that includes a low-dose ICS. MART stands for Maintenance and Reliever Therapy. It is a form of combined ICS and LABA treatment in a single inhaler. It is only available for corticosteroid inhaler and long-acting beta-2 agonist combination, in which the LABA has a fast-acting component, for example, formoterol. In the next step, you can increase the low-dose ICS in MART therapy to a moderate dose ICS. Or you can change back to separate doses of moderate dose ICS and a separate LABA. Finally, at the end, you can either increase the corticosteroid inhaler to a higher dose, but only as a part of a fixed dose regime, not as a MART therapy, or you can add an additional drug, for example, long-acting muscarinic receptor antagonist or theophylline, or you can seek advice from a healthcare professional with expertise in asthma. Now let's revise the BTS and NICE guidelines quickly. So according to BTS guidelines, the first step is to start with short-acting beta-2 agonist inhaler as required. The second step is to add corticosteroid inhaler at the lowest dose. The third step is to add inhaled long-acting beta-2 agonist and assess the control of asthma. If there is good response to LABA, then continue LABA. If there is benefit from LABA, but the control is still inadequate, then we continue LABA and increase the lower dose of corticosteroid inhaler to a moderate dose. And if there is no response to LABA, you stop LABA, increase the corticosteroid inhaler to a moderate dose, and add another drug like leukotriene receptor antagonist or theophylline, etc. In the fourth step, you increase the moderate dose of corticosteroid inhaler to a higher dose in addition to leukotriene receptor antagonist, theophylline, etc. And finally, in the end, you can use a daily steroid tablet in the lowest dose possible, providing adequate control. According to NICE guidelines, the first two steps are the same as the BTS guidelines. That is, we start with a short-acting beta-2 agonist inhaler, followed by a low-dose corticosteroid inhaler. However, in the third step, we add a leukotriene receptor antagonist. Then we assess the patient's response to leukotriene receptor antagonist, and if the response is inadequate or if there is no response, then we add a long-acting beta-2 agonist. If the patient is still symptomatic, then you switch the ICS and LABA to a MART regime. If the patient still has symptoms, then you increase the low-dose ICS to a moderate dose ICS, either within a MART regime or as a separate dose. And if the asthma is still uncontrolled for 4 to 8 weeks, then either consider increasing the ICS to a higher dose, or consider adding another drug like LAMA or theophylline, or seek expert advice from someone who has expertise in asthma. That's all for today. If you want to see more videos like this, then keep following Dr. Zainab Mohsin, and don't forget to share it with your friends. Take care. God bless you all.